Hi, my name is Rohan Gupta, and today I'll be presenting the research thus far on my evaluation of the CMS EHR incentivization penalization strategy and its effectiveness in reaching Healthy People 2030 hypertension goals. Just some background, EHRs, or electronic health records, are real-time patient-centered records that make information available instantly and securely to authorized users. Overall, EHR reporting must contain, as it lists here, electronic prescribing, health info exchange, provider to patient exchange, public health, and clinical data exchange. So CMS uses these Healthy People 2030 metrics to enumerate their population health goals for 2030. So by 2030, CMS wants to reduce the proportion of individuals 18 plus with hypertension from 29.5% to 27.7%, and then increase the proportion of 18 plus individuals with hypertension that have hypertension under control from 47.8% to 60.8%. And just as a quick note, self-monitoring of blood pressure has empirically shown accuracy in both a home and clinical setting for both measurement and diagnosis of hypertension. And then some just guiding questions. The most important one, I suppose, is how do patients with poor access and at the highest risk most commonly use EHRs? Just some quick methods. So this study, in terms of study planning and setup, this patient cohort was identified as 280 patients from Lincoln Community Health Center with severe hypertension, clinically diagnosed severe hypertension. And all these patients have been given a blood pressure cuff in previous community outreach efforts. In part, the study is a follow-up intervention to one conducted by Dr. Granger and Dr. Biola. These patients are what we called Group 2. Members of the research team for this intervention, for the Group 2 intervention, only had access to the name, MRN, and phone number of participants. So in terms of study implementation, the patients in the cohort were divided among students. These individuals were asked a series of questions about their blood pressure, MyChart status, and interest, and if they needed any community referrals or assistance that we could potentially help them with. These responses were recorded in a spreadsheet, and Dr. Biola reached back out to participants who required assistance with these community referrals. And at the time of the poster, 179 out of 280 patients had either been contacted or called thrice to rule out their participation in this intervention. And for the purposes of this poster, data collected as of 7/17/2021 will be analyzed. In terms of post-study evaluation, it's ongoing. It's pending full results. We're not quite done with the intervention. We still have however many individuals to contact left. But basically, the study will be used as further evidence, one or the other, in a policy review discussing ways to use EHR to decrease hypertension prevalence in the United States. So just some quick facts. So 84 out of 280 patients were spoken with at the end of the day, out of the 170 we contacted. 43 patients had MyChart, 39 did not have MyChart, and 2 individuals were in the process of setting it up. These charts below show the reasons for MyChart portal use and for non-use or not signing up. Multiple reasons were reported for both use and non-use. So we gave patients the freedom to give a multitude of reasons or one reason as to why they didn't use or did choose to use MyChart. The most prevalent reasons for using MyChart were like retrieving lab results, making appointments, and messaging. And the high proportion of messaging could be leveraged for future patient-provider communication regarding self-monitoring of blood pressure. And I guess we'll touch on that more when we have all the data collated. But again, there were a high number of patients who had multiple declared uses for MyChart. And again, we can't make any solid conclusions. So we just said that this could suggest that when individuals access and understand how to use MyChart, they tend to take advantage of a wider variety of features, which is a net good for the health landscape. In terms of key observations, the most cited use of MyChart is for making or viewing appointments. That's APP. It's shown in blue on this chart. The most cited barrier to using or registering for MyChart is inconsistent or non-existent access to internet, which is labeled as no int, which is this big light blue semicircle here. So the 23 individuals who cited viewing appointments as their main use for MyChart, 20 of those individuals cited a second reason for using MyChart, and 8 cited 3 specific reasons for using MyChart. And then of the 8 who cited no internet as their main reason for not having or registering for MyChart, 4 of those 8 cited a general lack of technology as well, which is really critical because it suggests that these things go hand in hand. That the digital, like the digital divide isn't just necessarily related to one condition. In terms of future steps, we'd like to complete this intervention and finalize data, run statistical analysis so we can, stop, I guess, beating around the bush and use more concrete language when we're discovering results. And I guess just overall subsequent analysis in order to, as we said before, inform ways to discuss using EHR to decrease hypertension prevalence. And I guess sort of ways to also increase access to using these EHRs, because the prerequisite to using EHRs to decrease hypertension prevalence would be to have a wider population utilizing these EHRs effectively. But yeah, I'd just like to thank Dr. Biola and Dr. Granger for giving me the exposure this past year and working this summer to sort of help me cap off the research that we've been doing together. I can't thank them enough for this exposure to the quality improvement process. And I appreciate everyone's time.